Dr. Jen, honey, it's such a pleasure to have you on the show. How are you doing today?
I'm doing well, thank you. I mean, I'm a little worse for the wear. I'm just off of the red eye. So if my brain is not quite as quick as it normally is, then you'll forgive me. But we're going to talk about stuff that's so important today. So I absolutely am delighted to be here with you.
Oh, I'm so just delighted to have you. I've been looking forward to this conversation for weeks now. And I'm just curious, before we even dive into all the questions I already kind of pelleted you with, what was that defining moment for you that like you knew in your heart of hearts, like this is the work I want to do.
Yeah.
These are the women I want to serve.
Yeah. I can honestly say that I didn't pick breast cancer. Breast cancer picked me without question. I was born into a breast cancer family, and all of the women in my family are affected by breast cancer for many generations. And when I really don't remember a time when I didn't know about breast cancer. Like as a child, this was part of the fabric of our family. And as a child, I had a first cousin growing up. Her name was Linda Creed. She was a singer-songwriter in the 1970s and 1980s. She was brilliant, beautiful, larger than life, lit up any room that she walked in. She was like infectious. Like you couldn't get enough of her and you couldn't help but admire her. And she wrote 54 hits in all. And her most famous song was The Greatest Love of All. So she wrote that song in 1977 as the title track to the movie The Greatest, starring Muhammad Ali. But it really received its acclaim in March of 1986 when Whitney Houston would release that song to the world. And at that time, it would spend 14 weeks at the top of the charts. Only my cousin Linda would never know because she died of metastatic breast cancer at the age of 37, 1 month after Whitney released that song. I was 16 years old and my hero died. It's so amazing to me that after all of these years, I still can't tell that story without tears coming to my eyes. And her life and ultimately her death gave birth to my life's purpose because I never wanted another woman, another family, another community to have to suffer the way that ours suffered. And so I did the only thing I knew how to do. I became a doctor. I became a surgeon. I became the first fellowship trained breast surgeon in Philadelphia. I was the first oncoplastic surgeon in Pennsylvania. And I was doing things that no one else was doing. And I really thought that I was making a difference and making an impact. And it was about 15 years into my career when arguably I'm at the top of my game. I am running the breast program for my hospital. I'm running the cancer program for my hospital. And I'm a wife and a mother and a friend and an athlete and a philanthropist. And I have all these balls in the air. And in what seemed like a day, went from one of the most high functioning people you've ever known to I couldn't walk across the room because I didn't have the breath in my body. So I undergo this intensive 3-day workup. And at the end of those 3 days, I find myself sitting in the office of my friend and colleague and physician. And he tells me that I need surgery and chemoradiation, and I'm going to be on lifelong medication. And despite the fact that these are things that I said all day, every day to my patients without hesitation or reservation, when those words are coming at you, they have a very different impact. And they were not well received by me. And despite the fact that I knew that this was the gold standard, this is exactly what I would have offered someone else in my very same position, something inside of me told me that there was more. A voice in my head said, there's more, find it. Because when I was asking the questions like, how could this happen to me? I'm healthy. The answer of it's just bad luck, or it's multifactorial, or it's just something that happens, or there's nothing that you could have done differently, it just wasn't acceptable. And so I went out, left that office that day, refused treatment. My doctor told me I was going to die. And you know, that's the same thing that I told women for years and years and years. who didn't want to treat their breast cancer. You know, what will happen to me if I don't treat? And I would tell them that they were going to die. And that is true if you don't change anything else. But I knew I had to undergo some change. I just didn't know what that change was going to be. But I knew, somehow instinctively knew, to go look for something. I was very fortunate in the beginning of my journey. I'm sitting in a lecture hall. I decided that I needed to learn more about nutrition because we get very little training around nutrition as a medical doctor. I was trained at one of the finest medical schools in this country and still almost zero training around nutrition. 15 hours in our first year of medical school, and I have 11 years of higher education and 15 hours in those 11 years.
And on top of like the amount of classes that you're going through at that time, it's just like a blur.
Yeah,
it's all a blur. It's probably one of those classes you're like, this isn't actually the class that's going to move me forward. So it's not even the focus.
Frankly, when we were in medical school, we had like 2 main semesters, right?
Yeah.
So we had August, we started in August, we went August through December, and then February through June. And in January, we had what was called mini courses. And one of the mini courses was nutrition.
Yep.
It was like they shoved a bunch of stuff in there that wasn't important, but they had some obligation to put it in the curriculum. So, and I have colleagues that like skipped mini courses.
Mm-hmm. I was going to say, a lot of people didn't even go through that, depending on.
It's not important, because if it were important, they would have put it in the body of our education, but they didn't do that.
Mm-hmm.
Right? I mean, I still to this day remember exactly when it was, and they taught us like ridiculous things like scurvy and rickets and things.
Yeah, no, it's vitamin C deficiencies, and it's nutrient deficiencies that you're learning. It's more biochemistry than it is anything else. It's not like real nutrition. I don't know. I remember.
Yeah. So I decided I'm going to do the certificate course with the Institute for Integrative Nutrition.
Mm-hmm.
And of course, like I drove them crazy first. Like, I'm a physician. Am I really going to learn something? Is this going to be worthwhile for me? And they kept assuring me, yes. So here I am sitting in one of the first lectures, and this tall, lanky guy walks on stage, big toothy grin, and he introduces himself as a functional medicine physician. Now, at this point, I had been a doctor for about 20 years, and my snooty booty self kept saying, there's no such thing as a functional medicine physician. Like, what is this quack talking about? And then I remembered that I'm sick and I'm there for a reason. So I checked my ego at the door and I listened. And thank God I did. Because what this man would have to say over the next 3 hours would not only be the key to my healing, but would telescope what I was going to do with the rest of my life. Now, as it turns out, this man, this quack, was Mark Hyman. But this was 2016. Like, I didn't know who he was. And if you're not in the functional medicine world, and if you're not in the integrative medicine space, and quite frankly, most physicians walk through their entire career with blinders on, right? They are so tunneled. They're so siloed. We learn what we learn in medical school, and then we do very little learning afterwards. Certainly no broad learning. Like if you trained as a surgeon, once you finish medical school and residency training, the only thing that you're required to is continuing education in your surgical field. And for me, I was so subspecialized because I was a fellowship trained surgeon who practiced surgery in one specific area. So that's where all my continuing medical education was. So I would have never learned what I ended up learning had I not gotten sick. And so being in that room on that day, listening to Mark Hyman speak about root cause disease, and learned that day that in conventional medicine, we are completely focused on the wrong thing. because we're focused on the symptom. In the area of breast cancer, we're focused on the tumor, but the tumor is not the problem. The tumor is the symptom of the problem. And you're never going to solve that problem by cutting out the tumor or by poisoning it or by burning it. That's not solving the problem. It may buy you some time, but in order to solve the problem, you have to figure out why the tumor was there in the first place. You have to go upstream. You have to figure out what is going on in your environment. Why has your environment shifted from the chemistry of joy to the chemistry of stress? This is the chemistry of joy that fosters health, and the chemistry of stress that fosters illness. And the breast, the thyroid, these are the canaries in the coal mine. And when we have that shift from the chemistry of joy to the chemistry of stress, cancer is a normal response to an abnormal environment. And we all need to be asking, where is that environmental shift happening? What is going on that is causing our cells to feel unsafe? Because that's exactly what's happening. We have a transformation. Our cells feel unsafe in their environment. And so what do? They transform. They go into survival mode. You know, you think about how an animal behaves when it's backed up against a wall, when it's cornered, right? They become ferocious because they feel unsafe. You know, I have a 5-pound poodle who's actually seated right behind me in my chair. He likes that spot. And, you know, 5-pound poodle, he's adorable. But if you back him up against a wall, he turns into 5 pounds of teeth. It's the same thing that's happening in our body. If your cells are in an environment where they feel threatened, where their survival feels threatened, they are going to transform. And they're going to transform. They're going to go into survival mode. They're just going to reproduce. Now, this is happening all day, every day in all of us. We all make cancer cells from the very young to the very old and everywhere in between, because as we reproduce our cells, we're going to make mistakes, right? We're not perfect. However, intact immune system should be able to recognize those cells and destroy them. The problem is most of us are walking around in an immunocompromised state because there are too many toxins, there are too many chemicals, there's too much stress, we're too busy, we're not getting enough sleep, we're not getting enough movement, or we're not doing the right kind of movement, and on and on and on. And all of these things are having a profound effect on both cellular damage and our immune system. And this is the recipe for cancer.
What's the recipe for autoimmunity? It's the recipe for neurodegeneration. It's the recipe for metabolic dysfunction. It's the recipe for cancer. It's the recipe for all kinds of issues and concerns. Everything I practice is root cause medicine. And we do live in a time where it's almost inescapable.
Yes.
So, you know,
Almost.
I mean, gosh, every day of my life is focused on doing all of the things. And it's so funny. I in a lot of ways, I'm the canary in the coal mine. I have a thyroid situation. I told you I had a biopsy this year, and this is despite how intentional I am every day. You know, I eat an anti-inflammatory diet. I take all the supplements. I have $1 million meeting with sleep. You know, I'm leaving for Dr. Joe Dispenza's Denver meditation retreat in 2 days.
Oh, I'm so jealous.
And as I mentioned, my sister's in emergency back surgery right now. So I canceled a lot of my plans before I left for Dr. Joe, to go and tend to my sister. And so even when we're managing our trauma and we're managing our stuff, like something comes up and you're just like, I gotta go do this thing. So I'm curious, you know, in terms of, I mean, obviously that's doing those types of lifestyle foundation, you know, living from a place of joy and not stress. We absolutely should all be trying to do so. But, you know, in the situation that we do get an abnormal biopsy or we do have a tumor growing, do you find, Dr. Jenn, it to be a yes and? Like, as you said, some of this buys you time.
It certainly can be a yes and, but, you know, just going back to the issue of biopsies, having an abnormal mammogram and having a biopsy does not equal having an abnormality in your breast, because the vast majority of these biopsies, 75% of breast biopsies, are done for benign disease.
Yes.
But this goes back to that fear mongering that we talked about.
Mhm.
And unfortunately, our system is designed that way and reliant on that because many women without the fear factor would not choose to engage in the system that we've built. And the system that we built very much creates customers by intention. Like
Agreed.
a lot of current medical system, they are customer creators. So, we have created this paradigm, especially in the area of breast cancer screening, where we tell women that mammograms save lives, and the data actually is not there to support it. When we look at one of the largest trials that we have, the Canadian breast cancer screening trial, we looked at 90,000 women from the ages of 40 to 59. Half of them got screened with mammogram. Half of them did not, and they underwent what's called routine care, where they would just get physical examinations. And there is no survival advantage, zero survival advantage to screening with mammogram. And the only thing that happens when we screen with mammogram is that we diagnose more cancers. And what that translates into is treating more women for cancer that don't need to be treated. Because when we look at the two arms, the exact same number of women died of breast cancer. And we could argue that the only people that need to be treated are the ones that present clinically, because the survival is exactly the same if you screen or if you don't screen. But the women that we treat for breast cancer are subject to all of the side effects of breast cancer treatment. So what that translates into is more cardiovascular deaths, more neurodegenerative disease, more osteoporosis, osteoporotic fractures, and more deaths and complications due to fractures. Plus, the quality of these women's lives is severely diminished. First of all, they're dealing with the trauma of a breast cancer diagnosis, which, there are few things as detrimental to health as a breast cancer diagnosis. And the treatments for breast cancer, most of which render women menopausal.
Yes.
So when you render a woman menopausal, she's going to have neurodegenerative disease. She's going to have brain fog. She's going to have depression. She's going to have anxiety. She's going to have sleep disturbance. She's going to have palpitations. She's going to have accelerated cardiovascular disease. We started off talking about the fact that exponentially more women die of cardiovascular disease in every decade of their life past 30 as compared to breast cancer.
Yeah.
So if we are curing women from breast cancer, but giving them cardiovascular disease, have we done them any favors? I can argue that, in fact, we have not, and we have done them a great disservice.
I have a question really quickly. Just a little bit about, the fascination around, I want to break a little bit of this down. The reason why I ended up getting a mammogram was I was trying to get full out HRT. And one of the doctors I was working with, she was a functional doctor too. Again, there's so much fear around it. She's like, you know what? Let's just check the boxes. You haven't had one, get one and get a pap smear. Maybe let's just make sure you're clear before we start you on this journey. A journey that I don't ever intend on getting off of, by the way, nor should I.
I am
I was
full supporter of hormone replacement forever.
And I just thought honestly, I just thought I was checking boxes, check, so I could get started. And did I really feel like I needed to check those boxes to get on HRT? No. But I thought, you know what? I get it. A very cover your butt type of situation, right? That's what she was doing.
CYA medicine.
Feel good about not having liability. And I was like, fine, I'll just go in and do it. I have insurance. I can do that real quick. And then it ended up going down this road of spiral. And I have a 3.5-year-old, and I'm not trying to go anywhere. I'm not, and so I ended up going down the road of all of this. And it's crazy to me because I think normally I would have just started HRT if I didn't have a couple friends in my ear about like, hey, let's just knock these other things out really quickly. And it feels like it felt like it just kind of spiraled out of control. And, again, I guess grateful for the journey. Yes, a little traumatizing, the whole process of waiting. One, it's hard to get into facilities. I remember from December, it took until April to get the biopsy. So it was a process. It was almost over 90 days of dealing with all of this. And so
Right.
it just, it's interesting to me, like you said, the build around this fear, that kind of leads us down the path of, thank goodness everything was benign. I was a part of the 70 or 80% of women who get these, and then everything's good to go. Although it did ask me and make me wonder what in my body shifted, or what even to bring about benign changes. I mean, should that be of concern as well? I remember talking to a dear friend of mine, Dr. Anna Kabeka, who's like, well, you have benign changes, like that's worth a consideration. And I was like, yeah, I mean, I think any changes in the body are worthy of consideration, sure. But I was curious, in terms of standard of care, just for women to get on HRT, what's your stance on that as well?
Yeah. So I don't think benign changes are meaningful, except to say that if you have a departure from normal, this is nothing more than opportunity. This is opportunity to take stock in what you're doing and see what's working, see what's not. It's a call to action, and treat everything up until invasive cancer as a call to action. Mm-hmm. So even a DCIS diagnosis to me is not cancer, and we should not be treating it like cancer, because it's not. But it is an opportunity. It's an opportunity to say, why has there been a shift in the environment of the breast? Why is your breast perceiving being threatened? And why do you have toxicity in the breast? And for a lot of people, it can be nothing more than increased level of stress, because when we think about the stress response is, we only really know two states. We know safety and we know danger. Mm-hmm. So safety is our parasympathetic rest, digest, repair phase. And danger is run away from saber-toothed tiger. That's all we know, right? We have this really basic instinct. So even though we don't have saber-toothed tigers, we have virtual saber-toothed tigers in our lives all the time. So if your body needs to run away from a tiger, it's going to divert blood supply to your muscles, and it's going to divert it away from non-essential functions. Mm-hmm. So this is why people under a tremendous amount of stress struggle with fertility, because that is not the time to bring a child into the world. So we're going to divert away from our reproductive system. Well, the breast is also a non-essential organ. So if you are in this stress state more than you're supposed to be, if you're in a cortisol dominant state more than you're supposed to be, and that's really, we're only supposed to be in that like 5% of the time.
And that's every woman, every diurnal cortisol lab I've ever looked at.
So the thing is, what's happening here is we're diverting blood flow away from the breast. Well, the breast happens to be repository for toxins, because when we look at the tissues of the breast, it's glandular tissue, it's connective tissue, it's fat, and it's all held together in a skin envelope. But even highly glandular breast will have a significant amount of fat cells. Well, fat cells are where we store our toxins. Mm-hmm. So any breast is going to be a storage place for toxins. So if you decrease blood flow through the breast, and you have a buildup of these toxins are having a local effect on the breast tissue. So they are having this DNA damaging effect on the breast tissue. This is why stress often presents itself as changes in the breast tissue. So I want to use these changes as opportunity. And even if you have a cancer diagnosis, if you can, instead of seeing it as a punishment, but instead seeing it as an opportunity, to reclaim your health, those are the people that really do great. And it's actually why I wrote The Smart Woman's Guide to Breast Cancer, because when we get these diagnoses, benign, borderline cancer, I wanted people to make an informed, educated decision. Right now, the decisions are made on fear. Everyone is so afraid. You got a biopsy because you were afraid. But had you, instead of having a mammogram, which is a very low resolution technology, and mammogram misses more than it finds, especially in dense breasted women, and ultrasound, which is also low resolution technology, if instead you had a QT scan, which is new technology. Now, they're not universally available yet, but I am working really hard on making sure that that happens. I'm opening the first perfection imaging in the suburbs of Philadelphia in just a couple of weeks. And I have plans to put up 7 this year and 50 in the next 5 years. So, because I want to make sure that everyone who wants access to this technology has access to this technology. But this technology is very high resolution technology without any danger, without compression, without radiation, using sound waves transmitted through a water bath. We are able to collect 200,000 times more data points than MRI and make a 3D reconstruction of the breast with 40 times the resolution of MRI. And so had you had that test instead of a mammogram and an ultrasound, it would have recognized that there was nothing there to be concerned about. And had we found something, we can bring you back for a short interval study, a study in 60 days, re-image the breast, count the cells, measure a doubling time, and we know that cancers have a doubling time of less than 100 days, and things that aren't cancer or aren't worrisome have a greater doubling time. So if you have a greater doubling time, we just say, see you in 1 year. And we know that it's nothing to worry about. You know, part of the problem with the system as it is right now is that it's totally based around fear. And we scare people into having mammograms, even though it's such inferior technology. And it actually has some danger associated with it, in that the more mammograms you have in your lifetime, the higher your risk is of getting breast cancer. They do deliver radiation to the breast tissue. And often the argument is, well, it's the same radiation that you would get on a cross-country flight, and you don't tell people not to travel. That's true. But the radiation that you get on a cross-country flight is diffuse radiation. It's scattered radiation. Whereas the radiation that you get when you have a mammogram is completely focused on the tissues of the breast. And because it is low energy radiation, 40 to 60% of that radiation will be retained in the tissues of the breast. And so it's additive. So I don't believe in subjecting the normal, healthy population to dangerous tests. So I don't even use screening mammogram in my practice at all, but I do evaluate a lot of people for hormones. And the people that I evaluate for hormones have already had breast cancer. So I can tell you that without question, the data is out there that hormone replacement is safe in the breast cancer population. And we know from multiple trials that hormone replacement is both safe if you haven't had a breast cancer diagnosis and if you have had a breast cancer diagnosis, if you have family history or you don't have family history, if you've had a hormone positive cancer or you haven't had a hormone positive cancer. It doesn't matter. If you are on hormone replacement and you get breast cancer, you actually have a better outcome as compared to the population of women who were not on hormone replacement when they got their breast cancer diagnosis. And if you've had breast cancer and you go on hormone replacement, you do not have an increased risk of recurrence. And in fact, the long-term outcomes are better for women who have had breast cancer and go on hormone replacement than the ones that don't. And the only trials that didn't agree with this have since been completely refuted, and retraction papers have been printed. So the Women's Health Initiative, which initially said that hormone replacement is associated with an increased risk of breast cancer. That has been completely retracted in a 2017 paper. And the Swedish trial that said that hormone replacement after breast cancer was associated with an increased risk of recurrence has also been retracted. And all the other studies, of which there are between 30 and 50 trials. Now, some of them are small numbers, a few hundred women, but still, we're seeing the same trend over and over and over again, in that there is a survival benefit to going on hormone replacement, and there is a quality of life benefit. That's not measured, but certainly when you have a better quality of life, it translates into longevity. Because the number one predictor of how long you live is how long you think you will live. And if you are miserable, you don't want to live long. If you're miserable, it's easy to quit life. But if you are happy, if you're comfortable, if you're feeling physically well, if you're not in pain, and you're able to connect and enjoy life, that's going to translate into longevity. So I'm a huge believer in hormone replacement, but this is how I evaluate people. I do not send them for mammograms because I don't believe in mammograms. I don't think that anyone should be having screening. I'm not throwing the baby out with the bathwater, and I never tell people that they'll never have a mammogram. I think that they are appropriate in certain situations for diagnostic purposes. If you already feel a mass, if you notice a change in the appearance of the breast, if you have nipple discharge, if you have some symptom and you're no longer in the normal population, I think that they're appropriate for a diagnostic study. I just don't ever use them for screening. So for my workup, I have a big lab panel that's looking at your metabolic markers, your inflammatory markers, because I want to know where you are in terms of your health. I'm looking at a full thyroid panel to see where your thyroid hormone is, because that is very important when you're replacing sex hormones, to see where the thyroid is. And then as far as studies go, I have my patients get a whole body thermogram every year, not as a screening test for breast cancer, as a screening test for inflammation.
I was going to say, is it for inflammation?
And that's what it is, and that's what it's powered for. And the reason that thermography got a bad rap is because people used it as a screening test for cancer. It's not a screening test for cancer. And there are plenty of cancers that are very slow growing and will not incite an inflammatory response. And so they're not going to show up on thermography. And that's okay, because that's not what thermography is, and it's not what it should be used for. It should be used as a screening tool for inflammation. And if I have someone who's highly inflamed, I want to know why before I start them on hormone replacement.
Yeah, exactly. I'm curious really quickly, Dr. Jenn, I was interested. So I look at biomarkers all the time. I look at inflammatory markers, and particularly around, like, I'm looking at homocysteine, I'm looking at fibrinogen, I'm looking at obviously highly sensitive C-reactive protein. Are there specific things that you are looking? I'm obviously looking at all the metabolic markers and then full thyroid panels. It's, particularly coming from the spectrum of inflammation and potentially even cancer and breast cancer. Are there specific markers that you are looking at when you are making these assessments? Because for me, I'm looking at inflammation more than anything, but I'm not specifically looking for inflammation that may be tagging something like breast cancer. I'm usually looking at metabolic stuff.
So inflammation is not necessarily, there's no like breast cancer inflammatory marker.
Right. No, I know that too.
Nothing specific to that. But I'm looking at all those same things. I'm also looking at a ferritin. I'm looking at a sed rate. I'm looking at all the metabolic markers, right? I'm looking at glucose. I'm looking at insulin. I'm looking at an A1C.
I like looking at uric acid as well. I just kind of looking at all the things.
So we're looking at all the things because we want to make sure that the person in front of us isn't inflamed, isn't, some of their markers are going to be off just as a result of having hormonal deprivation, right?
Yeah.
So the lipid
it's called menopause and perimenopause.
Yeah. So things are going to look different.
Favorable direction. See that happening.
Yes. So they're going to lose some of their insulin sensitivity. Their lipid panel is going to look different. And we recognize all of that, right? But what we're looking for is something outside of the ordinary. If they have significant thyroid dysfunction, if if I see the joints lighting up all over the place on, there are things that I look for that say to me, do I need to be looking further? Is this person someone who I should be looking at a mycotoxin panel? Should I be looking at a metals panel? Do I have to worry about inflammation that's happening in their mouth, right? So I use that, I call it my big lab panel, to just give me an indication, like, should I be working with this person a little more before I go to hormone replacement? And the imaging that I use, if I have a QT scan available, I do. So, the people that come to see me get scanned at my facility, and I use that to clear the breast, more or less, right? But I'll take an ultrasound too. I'll take an ultrasound. That's fine with me, because I'm not looking to see, do they have microcalcifications and do they possibly have DCIS? Because I'm working with them to make sure that all the pillars of health are put in place anyway. And if they have some major source of inflammation, I'm going to flag that anyway. I'm going to find it anyway, because it's going to show up on their labs, and I'm going to work that up. I think that everyone kind of has their own criteria. Mine just differ in that I don't require women to have mammogram. I think that there are better ways to clear the breast. And I also really believe in self-breast examination. Because I think that no one is going to know you better than you know yourself, ever. And that if you find something in your breast, if you find a change, because believe me, every woman thinks that her breasts are lumpy.
Well, they're dense at this age, at least at mine. My son, who I finished breastfeeding,
you're a young woman.
year,
They're supposed to be.
They're supposed to be dense. He calls them heavy. He calls them heavy TTs. And I'm right at the late luteal phase where they're the heavy TTs is what he likes to call. And he loves this phase of my cycle. Me, not so much, it's not my favorite phase in perimenopause, but my son is heavy TTs. And I'm like, and I don't go into all the nuance of the physiology, but
of course not. But that's another thing that we've created this tremendous fear around dense breasts.
Yes.
Let me tell you something. Young women who are able to have a child and feed a child, you're supposed to have dense breasts. You're supposed to have a significant amount of glandular tissue, because it's the glandular tissue that actually produces breast milk. So you're supposed to have dense breasts in the premenopausal phase. So we shouldn't be talking about that being a risk factor for breast cancer in a premenopausal woman, because it's not.
Yeah, it was really fascinating in my mammogram experience. Was they're like, your breasts are really dense. Like, it was this thing. And I was like, aren't they supposed to be at this age? Like, I'm in early perimenopause and still normally cycling. I feel like that's normal. But it just felt like this stigma of like, it was just interesting. And I was like,
but that's the fear, because unless they use that, what's going to make you come back for that mammogram in 6 months, and then again in 6 months, and then again in 6 months? And so they use all this fear signaling. It just gets worse along the way. Like, people are afraid to not go get a mammogram, so they go get a mammogram. And there's a finding on the mammogram that's most likely benign, but they're afraid that it might be cancer, so they have a biopsy, even though 75% of our breast biopsies are done for benign changes, which makes them totally unnecessary.
Yeah, the fear, the follow-up for me to get this 6-month review after the biopsy is pretty intense. Like, they're like,
it is.
Did you book it? Did you book it?
Yeah, but
have you booked?
You had a benign breast biopsy. What are you following? Right? Like, there's nothing to follow.
I haven't scheduled the obviously haven't scheduled, but I found it fascinating.
But that's the fear.
I'm usually on the other side of this experience. I'm the one, I'm looking at the labs, I'm looking at all the things, I'm doing the diagnosis. Obviously, breast cancer is not my area of expertise. Perimenopause, metabolic health, and hormones is, and thyroid and reducing inflammation, all those things. But to be a patient in this world, to be on the other side of things, I'm really grateful for the experience and how intense it is. No wonder, women are running back to get these follow-ups, because the languaging is so scary. And
that's exactly right.
Yeah.
And it's even worse for women with breast cancer. So they get this diagnosis, they're terrified because nothing rattles your earth more than those 4 words: you have breast cancer. There's nothing more terrifying to a woman, because not only are they worried about their life, they're worried about their sexuality, they're worried about how they're going to look, feel, behave. They're worried about their identity, how.
Yeah, and their family. I think a
Yeah,
lot of
of
these women,
course.
I know for me, I mean, it was my child that popped up
Yeah,
immediately. And I'm like,
yeah,
that's my come through in everything that I do. And so I'm like,
yeah. I
he's too
mean,
young.
that was the first thing that I thought of when I got sick, was I have young kids. Like, how can I'm not done yet.
Mhm.
I'm not done yet. And I love my husband, but like,
But yeah, he wasn't the first thing that came into my mind.
not well, and also like, my kids weren't ready to be left with him.
Right.
So,
I'm leaving town next week and my son's like, I don't love you, Dad. Like, I need mom. Like, and I know he just means that he would, he wants his mama there.
yeah,
So
that won't change anytime soon.
I know
I
it
can
won't.
tell you at 15 and 18, it's still as true
It's still
as ever.
true. So how did you, I know we're getting closer to finishing up, but and I know every woman is different. And mind you, all of us are dealing with compounding layers of stressors, whether it's trauma from long ago, it's chemical stressors. We just did a big mold remediation at the exact same time I was dealing with this biopsy. My mycotoxin levels are out the roof. So there were a lot of things that are compounding that made me wonder, like maybe I should just make sure I'm good. So a lot of us, there's layers of things, and you and having that moment, that defining moment where you are getting sat down and you're getting told the thing that you've been telling women: you've got breast cancer. This is what needs to happen. Here's your protocol. This is the standard of care. All this is what you've been doing. And you go and seek different answers. And obviously nutrition being a big piece of that, getting inflammation under control, a big piece of that. What was that journey for you, and how has it translated for your women in your practice?
Well, the first thing I'll say is that I don't know what gave me the confidence to step back and look for answers, because what happens to most women is that they are so afraid.
Yeah.
That they actually don't step back. They don't think. They feel very rushed to do whatever they're told to do. And the system, by intention, really doesn't want them to think, doesn't want them to consider. They want to get them booked into these treatments before they do step back and think, what is right for me? And these treatments are very standardized. Everyone's getting offered the same thing, and there's no consideration to, you have something a little different, or this is what brought you to the table. I mean, they're not even thinking about the root cause. So again, why I wrote my book, The Smart Woman's Guide to Breast Cancer, is because I wanted people to be able to make an informed decision. I wanted them to understand their disease. So there's a whole explanation what those pathologic diagnoses mean. And then there is an entire explanation about all the treatments, what they do, what they don't do, because people don't have any clarity around that. All the questions to ask your medical oncologist, to ask your radiation oncologist, to ask your surgeon, to ask your reconstructive surgeon, to ask your integrative oncologist, because it's really important to understand what's happening with you and what the right treatment is for you. But in addition to whatever conventional treatment you choose, and you may choose all of it, you may choose none of it. For me, the functional medicine side of it, that's the and. No matter what you do, you need to do the functional medicine stuff, because the functional medicine stuff combines the pillars of wellness. And that's where I talk about eating in a way that's nourishing for you. Not everyone is going to be on the same diet, right? There is no one diet that's right for everyone. There's not even one diet that's right for everyone with breast cancer. However, I think what all of us can agree on is that processed foods are not good for anyone. And so advocate for a whole food, plant-based, low glycemic, grain-free diet, because I think when you eat within those confines, you are getting the things that nourish you and avoiding the things that hurt you. And so, that's what I advocate for. But I also give the caveat that what works for you right now may be great, but it's probably not what's going to work for you forever. And I think that the way that we eat does change over time and needs to change over time, even when we consider fasting windows and eating windows, because that should be changing with the time of the year. And you should shorter fast during the summer where you have way more daylight hours, and longer fast during the winter when you have less daylight hours, because we all need to be with circadian rhythm.
Absolutely.
And be tied into the rhythm of the sun. And we're meant to eat during the day and not eat at night because, again, we are modern beings living on a very old gene code. So if you were out eating it, you were probably going to create a lot of smells and going to become someone else's food. Right?
Absolutely.
So, we still have to revert back to that evolutionary program. So I think that how to eat changes over time, but that we all need to be avoiding processed food. How to move is very, very important. We need to be moving our bodies every day. And that also changes over time.
Mm-hmm.
Because as we get older and as our hormonal profile starts to change, the maintenance of our lean muscle tissue has to become a priority, because that is the metabolic center of your body. So we have to maintain that lean muscle tissue. We have to build that muscle. And so that is absolutely a pillar of the foundation of our health. We need to have healthy ways to manage stress. The stress is never going anywhere. We're always going to have stressors, and it's not the stress that matters. It's how we deal with the stress, what we allow to internalize that matters. And so we have to build resiliency. You're going to do that program with Dr. Joe Dispenza. And I mean, that is the key to his program, is just being resilient.
And I'm so excited. It's my first big trip away from my son. And it, I'm so excited. I'm finished. I know we got to finish up. I have another interview coming in, but the last question, in terms of, I know so many women come to you for hormone replacement therapy, and so many women are feeling very discouraged by their doctors, even their integrative oncologists around hormone replacement therapy. We're gonna have the book in the show notes specifically so that everyone can get it, so that they can understand how to navigate that conversation if they've had breast cancer and they're trying desperately to have a better quality of life. But is it that when you're getting the runaround with your doctor to find someone else?
Yes, absolutely. I mean, first of all, get a copy of Estrogen Matters by Dr. Al Brown Blooming, and buy one for your physician who tells you that hormones are dangerous, or you can't take hormones, you're not a candidate for hormones, or buy them a copy.
I love that book. I've read it so many times.
Called Happy Healthy Hormones by Dr. David Rosensweet. And that's another one that your physician needs to read. It's a little heavy for the consumer, but I think it's another really important part of work that demonstrates that hormones are for everyone, and that there are safe ways of administering bioidentical hormone replacement. And that if you are working with a hormone-literate physician or provider, it's not just physicians, or multi-level providers that are hormone literate, but it's very important to work with a hormone-literate provider, and most providers are not.
Yes.
Medical oncologist is not hormone literate. Most gynecologists are not hormone literate. They are not taught that in medical school. They are not taught that in residency. I'm telling you that it should be a formal training program. And I think that is on the horizon, where they're going to be offering fellowships in perimenopausal and care. But until then, you're going to have to do your own research and find a hormone literate provider. And that hormone literate provider will know that hormones are safe and they're necessary. The estrogens these are the hormones of life. And when we no longer have them, we have tremendous dysfunction. And all of our goals as providers should be to have people live as long as possible and die young. And that is possible, but it's only possible if you do the right things to preserve people's health. So that means helping them eat in a way that nourishes them, helping them move, establishing a healthy sleep habit, getting rid of toxins, having detoxification practices, living connected, purpose-driven life, and being provided hormone replacement after menopause, because that is what keeps our systems working the way that they are supposed to work.
Agreed. Agree with you 100%. Thank you for jumping on. Thank you for your beautiful knowledge and expertise today, Dr. Simmons. It's been so helpful, so refreshing. And again, where can we find you? We got the book. I'm going to put that in the show notes. Anything else you want to send our ladies?
Yes. So my practice is called Real Health MD, and you can find that online and find out about our programs. Perfection Imaging will be open in the Philadelphia suburbs in just a couple of weeks, and perfection is spelled with a QT in the middle.
Nice.
And then I'm on all the social media outlets at Dr. Jenn Simmons, and my Jen has 2 N's. I have a podcast called Keeping Abreast with Dr. Jenn, and you're going to be on my podcast very shortly. So we'll be able to do that little exchange, but you can find my podcast anywhere where you listen to your podcast.
Thank you so much, honey. It's such a pleasure. And I'm so excited for this. Yeah. For women to get your book, to get this beautiful resource, and to feel more empowered about these decisions.
As well they should. Yeah.
Thank you.
Absolutely. Thank you so much.